We're talking with Dr. Lynn Butterly, the director of colorectal cancer screening at Dartmouth-Hitchcock, about ways to gauge your risk for getting colorectal cancer. We talked about colorectal cancer being a serious cancer and also relatively common of the types of cancers, and also a cancer that can be prevented. Are there certain groups that are more at risk for getting colorectal cancer, and what are the factors that go into determining that risk?
Right. So another great question. There are different gradations of risk, and one of the very important things that a provider considers when you figure out which test is appropriate for a given individual is that individual's specific level of risk. So what I mean by that is there are basically three categories that are frequently used to assess risk. So there are people who are at average risk, at increased risk, which means a little more than average, and high risk, which are the high-risk groups. People in the average risk group are the folks who've turned 50. They don't have a family or personal history of an adenomatous polyp or of
colorectal cancer or potential to develop into colorectal cancer? Is that
right,
what that means?
yes. So an adenomatous polyp or colorectal cancer. They don't have a personal or a family history of colorectal cancer or polyps, and they're 50. So they are at average risk. People who have a past history of an adenomatous polyp or of colorectal cancer, or a family history of colorectal cancer in a close relative, and we can talk more about what that means, are at increased risk. And for those people, the screening recommendations are a little bit different. And then there is a very small group of people who have what we call familial syndromes in their family. It's something like the breast cancer genes that can be inherited that greatly increase your risk of getting breast cancer, the BRCA genes. The same situation exists for colorectal cancer. There are genes that can run in the family and that increase the risk within that family for colorectal cancer because it's a genetic syndrome and because they are able to either have hundreds, if not thousands, of polyps, which is familial adenomatous polyposis, where the colon can be covered in polyps, and that's detected at a very young age, or hereditary non-polyposis colon cancer, or HNPCC, also known as Lynch syndrome, where the polyps are few, but the ability for those polyps to turn into cancer is much greater, and it also the process happens much more quickly. So for the groups, there are also other genetic syndromes. Those are two common ones. So for people who are in this very high-risk group, which is a very small number of people, it's very important to be followed by a specialist, and if you have a strong family history, multiple relatives who've had colorectal cancer or other cancers that actually may be associated with Lynch syndrome, endometrial or uterine cancer being a common one, but there are others, then that's a history you would want to tell your provider. Oh, by the way, I have multiple relatives who've had these cancers. Is there something different I should be doing? It's important for your provider to know how closely related you are to these relatives, how many of the relatives there are, and the age of the relative at diagnosis of the cancer. All of those things are important as we try to decide what's your risk. So to leave the high-risk group aside, because that is something that definitely should be discussed with your provider and with a specialist, so we have the average risk folks who are 50, they have no family or personal history, and they are the people for whom the various options for colorectal cancer screening are appropriate. And then we have the increased risk group, which is a group of people who are at higher risk of getting polyps or cancer, and those are the folks who've either already had a polyp or colorectal cancer or who have a close relative who has had colorectal cancer or an adenomatous polyp in some cases. That also increases the risk, not as much. What we mean by close relatives: first-degree relatives are parents, siblings, and children. But if you have more distant relatives, but they're on the same side of the family and all related to each other, that's also an important history to tell your provider. So knowing your family history of specific cancers and knowing which relative and how old they were at diagnosis, not at death, but at diagnosis, is very important to help your provider choose the right test for you. And the way we choose the test is by assessing your personal level of risk. How likely are you to have polyps or cancer? And then picking a test that matches appropriately to that level of risk so we can protect you the best way we know how.
Would that change how often I would have screening tests if I'm in an increased risk group?
Yes, so that would also change. So if you have had a polyp or a close relative, particularly if the relative was younger than 60 at the time they developed the cancer, both of those things would put you more on the 5-year plan than the 10-year plan. And the person doing your endoscopy, who knows whether you've had polyps, who knows whether they completed the test, who knows how well they could see, in other words, how good was your prep, that is the person that will help your primary care provider to determine when you should come back. Because there are a number of factors that are important, not just what we found and not just your family history. Those are critically important in when you come back, but we also need to know that we saw your whole colon and that we saw it well in order to decide which plan you're on for follow-up.
We talked about 50 years old being the age that most people should get colorectal cancer screening, at least I believe that's what I heard. Mm-hmm. If a person is in an increased risk group, not the high risk group, but just the increased risk, might they need to get cancer screening at an early age?
Absolutely. Another really good question. So if you have a close relative, a first-degree relative with colorectal cancer or adenomatous polyps, then instead of starting screening at age 50, as we would do for average risk people, we start screening either at age 40 or 10 years younger than the age of the close relative when they got the cancer. So let's say you have a sister who had colorectal cancer. If the sister was 65 at the age of getting the cancer, she got cancer at 60 or 65, you would start screening at age 40. But if the sister was 45 when she got the colorectal cancer, then instead of age 40, it would be 10 years younger. So it's either age 40 or 10 years younger than the age of the relative when they got the cancer, whichever comes first.
Whichever is the youngest age.
Right. So if 40 comes first, it's 40. If the relative was less than 50 when they got cancer, then the earlier than 40 is going to come first. So it's whichever comes first. You want to talk to your provider. Make sure that when you tell your provider that you have a family history of colon cancer, that you tell them which relative and how old they were at diagnosis, because that's going to be very helpful in terms of following guideline recommendations for when you should start. People who have those hereditary syndromes that we mentioned earlier, which is a very small group of people, for people in those families, screening surveillance, as we call it, can start much earlier in life, much earlier in the teens or age 20. So that's a situation that you want to have discussed with your provider as soon as you realize there may be a strong family history. But for people who have 1 or 2 close relatives with colorectal cancer or adenomatous polyps, you want to follow up with your provider, even if you happen to be 35, because if you have a relative who was 45, it may be time to start.
45 when they were diagnosed.
When they were diagnosed. Then you would start 10 years younger. So talking to your provider is a good idea because they can help you to sort that out. But yes, definitely we might start screening at an earlier age, depending on the specifics of the family history.
Perhaps this is a controversial question, but I assume people will want to know, are there ways that they can reduce their risk of getting colorectal cancer?
Well, screening being the most important one. There are other things to do. As with anything else in life, following a healthy lifestyle, eating a healthy diet, not smoking is important for colorectal cancer, not being overweight, getting some exercise, all the things that in general help you to maintain your health will help you to lessen your risk of colorectal cancer. Smoking is a big one that people have control over, and obviously for other reasons as well. But it is particularly important to have screening and to realize that no matter how healthy your lifestyle, it cannot totally protect you from developing polyps or colorectal cancer. And the only way that we can be sure to do that is that in addition to your healthy lifestyle, you want to have screening.
That was a question I was going to ask, if you ever found that people take that too far and say, well, you know, I eat a vegetarian diet, I never smoke, I exercise constantly, so I don't need to do what everyone else does, and because I'm so much healthier than everybody else, so I don't need to do screening.
Well, sure, we hear that all the time. People are always trying to sell us on all the reasons why they don't need screening. But it is certainly important to be healthy, very important not to smoke, but you cannot eat and not smoke and follow a healthy diet yourself out of colorectal cancer. Or any other cancer. And so you do want to do the important preventive health things as well, in other words, undergoing screening, the test that you and your provider decide is appropriate for you.
This Healthy Highlight is brought to you by Dartmouth-Hitchcock and Ledyard National Bank, working together with our community partners to improve your well-being.